right? And so yeah, my disclosure is that I'm a speaker for the two companies. I'm Neil and Kieran. And again, the stuff presented here is not biased by my, arrangements. They're completely unrelated to this. I will be mentioning about the drugs, the Rytary and Nourians, but I will be mentioning about other drugs as well. So in no shape and form, this influences the content of the presentation. And then the objectives would be to discuss medical and surgical treatments of Parkinson's disease, talk about newly approved medications, talk about drug in developments and promising clinical trials. So again, the major slides, like typical, information about Parkinson's disease, I'm not going to dwell about because you've heard this before, but we know that Parkinson is a second most common neurodegenerative disorder, and more than 1 million people in the US live with Parkinson's disease. And it's associated with dopamine depletion of the cells in the brain that make dopamine. And also there is some Lewy bodies being deposited in the neurons. These are like misfolded alpha-synuclein proteins that are toxic to the brain, and they're being deposited in the brain. And then the clinical characteristics of Parkinson is the rigidity, which is stiffness, slowness. You could have rest and tremor, but 25% of patients with Parkinson's disease never have rest and tremor. So that tremor is not a sort of a requirement to diagnose Parkinson. And it does respond to carbidopa, levodopa. There's a typical picture of someone with Parkinson's disease. You have stooped posture, reduced arm swing, shuffling gait, stiffness, and the tremor. And but again, you don't need to have everything. This is a textbook, but not each individual patient can be different. And the other features could be postural instability, meaning poor balance, smaller handwriting, drops in blood pressure upon standing, and depression can occur as well. Freezing is a term that we use when describes the situation when your feet get stuck to the ground, when you're walking, when you're trying to turn, when you initiate gait, when you go through narrow hallways. That can happen as well, but not everybody at all. And then I just described that the freezing motoric block when you start walking. And so what do we do? Physical therapy. That the pills don't help for freezing, for balance pills don't help. Pills only help for stiffness, slowness, and tremor somewhat, not even tremor. Stiffness, slowness is the two things that pills usually help for. And that's why physical therapy is so important, because that's the only thing we can do for the balance. Now, okay, in terms of the non-motor, we talked about the motor problems, but there are a bunch of non-motor symptoms that do exist. At some point, they might develop. Again, the key word is might, not will. So if you see someone who is the symptoms, please do not approximate. Do not think that same thing is going to happen to you, because it might not. Specifically, hallucinations can occur in folks with Parkinson's disease. We have 2 medications for that. So I'll be kind of mentioning symptoms and medications. For hallucinations, we use Nuplazid or quetiapine. For memory loss that can occur, we use rivastigmine. It's a patch or a tablet. Orthostatic drop in blood pressure. So when you stand up, you feel dizzy. Elastic stockings are good, more salt in the diet. If that doesn't help, we use one of these 3 medications, Northera, which is very expensive, fludrocortisone, and midodrine. These are definitely affordable. Constipation, everybody with Parkinson's disease gets constipation, 100%, no exceptions. Use Miralax to prevent it. Don't wait for it to happen. Take it every day preemptively. RBD, it's called REM sleep behavioral disorder, kicking and screaming at night. Happens often. If it happens more than once a week, you should take clonazepam at nighttime, and that would prevent that from happening. Otherwise, you can injure your bed partner, you can fall out of the bed. So that's important too. But if it happens once in a blue moon, it makes no sense to take the medication, because you have to take medication every night. You don't know which night you're going to be having these issues. So, but if it happens often, then the clonazepam is the way to go. And then this is a sort of summary of the different classes of medications we use for Parkinson's disease and the mechanism of action described on the right side of the slide. So we're starting with carbidopa, levodopa, which is the main, probably the oldest medication and the strongest for sure. And that turns into dopamine in the brain. Then you have dopamine agonists, and then they kind of stimulate the receptors of the dopamine. They're not as strong. You have MOB inhibitors. These are the 3-selegiline, rosagiline, and Xadago. They prevent degradation of the dopamine. You have COMT inhibitors, it's a corticolamine monotransferase, also prevent degradation of levodopa. And these are 3 examples, entacapone, tolcapone, apicapone, or Agentis is the newest one. Then you have anticholinergic drugs that help for tremor mostly, but they're very nasty side effects. I don't give it to anybody. It's called trihexyphenidae. Back in the early 20th century, we used to use it before levodopa was discovered. Levodopa became available in 1968. Before that, we had no choice. We had nothing. We only had trihexyphenidae. And it works for tremor great, but it causes memory issues, dry mouth and constipation and sleepiness. So we don't use that anymore. And then some other medications such as amantadine, you might have heard of it, or Glycabri or Osmolex. That's usually used for involuntary body movements when people have so-called dyskinesias. Involuntary body movements, we use those medications. Also, occasionally, I use amantadine for tremor, and it doesn't help that much, but really, people usually tolerate that okay, so people take it. That's in a nutshell all the classes except for one. One class was not mentioned here. It's adenosine A2A antagonist called Nourians or estradiol. It's the newest addition to the table. It's a new class. It works through adenosine. The idea is that it also enhances the action of dopamine. So it's not very strong, but it helps. It's an add-on. Add-on medications. So now let's talk about wearing offs because this is important. A lot of you might have noticed, I don't know if you take levodopa, but initially levodopa works great. We call it honeymoon period. For 5 years, it works great. After 5 years, you notice that the times between the doses, you start noticing kind of wearing off. So you need to take the dose sooner or you got to do something about it. So I'll tell you what to do about it. And we call them wearing off of the levodopa. Specifically pertains to the situation when someone takes levodopa, it works, but then it stops working before next dose is due. So then what do? You can switch regular levodopa to Rytary. It's a long-acting version of levodopa. You can increase levodopa frequency and take it more frequently. That's another alternative, but it's less convenient because you have to take it more frequently. And then you can add enhancers such as the dopamine agonist. You can add COMT inhibitor or MOB inhibitor, those medications I mentioned as add-ons or enhancers. So I do recommend polypharmacy because that allows us to use different classes of medications at smaller doses, and those will not cause side effects. Remember, side effects are usually dose dependent. So the higher the dose, the more side effects you're going to get. But if you use drugs from different classes that work differently, but in a smaller doses, you're not going to get side effects, but yet you're going to attack the disease from different angles, if you wish. So polypharmacy is advisable in these situations. You have to remember one thing, that increasing the dose of the medication will not make it last longer. Let's say levodopa, right? It stops working after 3 hours. You say, well, I take 1.5 pills. Why don't I increase it to 2 pills of each time? It's not going to make it last longer. It's going to work stronger while it works, but it's still going to wear off in 3 hours. Or 3 hours is just an example. It could work 3 hours, 4 hours, 5 hours, or 2 hours. So depending on the state of the disease, the longer you have disease for, the shorter duration of action of levodopa. So it's estimated that by year 5 into the taking levodopa, 50% of patients developing wearing offs and having these wearing offs. So it's very common. Now, other common condition we see in Parkinson's disease, those patients who take levodopa, they develop levodopa-induced dyskinesias. These involuntary body movements associated with, you might have seen Michael J. Fox on TV, and so he's been on levodopa for 20 years, and so they're developing these dancing movements like that. And this is not part of the disease. This is a side effect to levodopa. If you take more than 4 pills of levodopa a day, each pill meaning 25/100, these are yellow pills. If you take more than 4 pills a day, your risk of developing dyskinesias go up exponentially. Now, what do we do? Well, I suggest to kind of use other classes of medications I mentioned in combination with levodopa. Not always it's possible to just take those enhancers without levodopa. You should have some levodopa on board and some enhancers as opposed to just use a monotherapy as levodopa alone. Because if you go beyond 4 pills a day, these in 5 years, you're going to develop involuntary body movements. treatments. So occurs 5 to 7 years after starting levodopa, mostly affects younger women. I'm not talking about women in their 20s. I'm talking about younger women, relatively young. The average age of onset of Parkinson's disease is 61. So if you have a 50-year-old lady, then she's more prone to develop dyskinesias on levodopa than a 70-year-old man. And what do? You can reduce amount of levodopa. That will improve dyskinesias, but at the price of you're going to get more stiffness and more slowness. So alternatively, you could take amantadine or Glycavri or Osmolex. These are all different types of amantadine that will allow you to stay in the same amount of levodopa, but reduce dyskinesia. So that's the way to go. Then other treatment options, you might have heard of medicinal marijuana, and the data is mixed. So it does help for tremor, anxiety, sleep, and kicking and screaming at night, but it does not help for stiffness and slowness. It's a possible improvement. In my personal experience, it does nothing for stiffness, slowness, but it only helps for tremor, sleep, anxiety. So you should know the limitation. Let's talk about newly approved treatment. I'm talking about within the last 3 or 4 years, newly approved. And that's a laundry list of these medications. So I'll just one-liner about each of these medications. So Rytary, it's a long-acting levodopa. It's the same as carbidopa, levodopa, cinnamide, but just long-acting one. You can take it up to 5 times a day. Inbrija, it's a rescue medication, inhaled levodopa without carbidopa, just levodopa, inhaled. So it's supposed to be used in conjunction with carbidopa, levodopa for breakthrough off, sudden offs, delayed ons. When you take levodopa, it doesn't kick in. It's a rescue dose. So you load it with 1 capsule twice, and then you inhale it, and in 20 minutes, you're good. And that good lasts for 1 hour. It's supposed to be a bridging therapy. 15% risk of coughs. A lot of people develop cough and are not able to tolerate that. It's $350 a month. Kinmobi, it's a sublingual rescue medication. It's a dopamine agonist that you put under the tongue, and it's supposed to help for the off, also rescue dose. And also in 20-25 minutes, it kicks in. Side effects, you might feel dizzy, you might feel nauseous, you might feel irritation under the tongue. Costs $250 a month. These are the 2 specifically rescue medications. The other medications are maintenance, not rescue. So Nurens, that's the new one that I told you about. It's adenosine A2A antagonist. It's used for wearing offs, used once a day. Xadago, it's a MOB inhibitor for wearing offs once a day. Apicapone, another enhancer of levodopa. It prevents degradation of levodopa for wearing offs once a day. Then you have Glycavri and Osmolex. It's a longer acting amantadine for dyskinesias. Northera is a new medication for drops in blood pressure, unaffordable. Nuplazid, it's antipsychotic. Actually, it's a good medication, and the company always finds the private investors, so the copay will be taken care of. Even though they're going to frighten you with the $1,000 bill, you don't need to pay. We can apply for a patient assistance program, get it covered. So, and Nuplazid is definitely good. If you have hallucinations, that's the way to go. So these are the newly approved medications within the last 4 years or so. And I'll be happy to answer any questions at the end of the talk about each of them. Again, the Rytary is the only levodopa that's longer lasting. Others are ideally add-ons, not to be used as a monotherapy. And some of them are used for other complications such as dyskinesias or drops in blood pressure or psychosis or hallucinations. Now let's switch gears and very briefly, talk about deep brain stimulation surgery, because I can spend an hour talking about it. But I would be really skipping a lot if I didn't mention that as a potential treatment. So it's been around for 25 years. And DBS stands for deep brain stimulation surgery. And the slide, the picture on the right slide depicts the insertion of the electrodes in a deep portion of the brain called globus pallidus or subthalamic nucleus. And they just put in these electrodes, and these electrodes are connected to the pacemaker, which is a regular pacemaker like you get for the heart, but instead of to the heart, the wire goes to the brain under the skin. It's traded under the skin behind your ear, so nothing is visible. But if you touch the neck, you will be able to feel the wire under the skin, and it's all concealed here, so you don't feel any horns or anything like that. What it does, it sends continuous stimulation to the deep portion of the brain responsible for the motor control, and your tremor is gone like you never had it in your life. Stiffness, slowness also is improved, and you get 4 extra hours of good time per day. So it helps for dyskinesia, motor fluctuations, reduction in off times. So it's like very powerful way to, it's like electronic version of levodopa, I call it. So you can do it in conjunction with levodopa, and in that case, you can cut the dose of levodopa in half. You can cut it in half, and you still need some, but not as much. Mind you, as levodopa, it does everything as levodopa does, plus it guaranteed to get rid of the tremor if you have it. What it doesn't do, I'll show you what it doesn't do. So this is what the pacemaker looks like, the characteristics of the size and the weight. It's unfortunately in metric system, but it's like 2 inch by 2 inch and the 2 ounces weight. Then who are the good candidates? So you want to have diagnosis of regular Parkinson's disease. There's some atypical variants of Parkinson we're not talking about today because it's a separate talk, such as multisystem atrophy, progressive supranuclear palsy, corticobasal degeneration. So the DBS is not good for that. You have to just have regular Parkinson's disease that the doctor should tell you whether you have it or not. And you have good response to levodopa. You should demonstrate that levodopa does help for stiffness, slowness, but either it wears off or it doesn't help for the tremor, because the levodopa might not help for the tremor, but it must help for stiffness and slowness. Good responders to levodopa do really well with DBS. And you could have issues with one or more of the following. We talked about that already. I had some patients who have nausea from levodopa. It helps, but they just feel nauseous no matter what. That's a good reason to put that DBS in, because that would do exactly what levodopa does without causing nausea. And then what are other things you should have as a good sort of a good candidate? Should have stable cognition. I'm talking about lack of dementia. The reason why is because if you have dementia and you do stimulation, your dementia will get worse significantly. So we do neuropsychological testing to make sure you don't have dementia before you're cleared to have a surgery. And you should have realistic expectation and good family support. Well, why am I saying that? I have one patient who was told, or she misinterpreted, that this is instead of levodopa. So she had that surgery done and refuses to take levodopa. So she does, her tremor is gone, but she still has some stiffness, some slowness, and I'm trying to convince herself, they misinformed you. This is not a cure. This is something you take in addition to, but you cannot take it instead of levodopa. So you have to have these expectations and also realize that it does not help for balance. It helps for stiffness, slowness, tremor, but will not do anything for balance. So if you think it's a cure, it's not a cure, it's a treatment. If you think your balance is going to get better, no, it will not. So as long as you have realistic expectations, so you're good. Okay, and then no comorbid depression or dementia. Depression, dangerous. If you have poorly controlled depression, it will get worse after this procedure. And this is no longer the case. We used to require at least 5 years of the disease, no longer the case. This is a window of opportunity. So in the sense that if you have your newly diagnosed patient with Parkinson's disease, your finger is flicking, and that's all, you don't need DBS. If you're in a wheelchair, God forbid, you had disease for 25 years and you cannot walk, or 30 years, what have you, and that's your major problem, you don't need DBS because it's not going to help you for your balance. It only helps for tremor, stiffness, and slowness. So that's why there is a kind of bracket where you get it. So these are the listed things for which DBS does help. And these are the things where you see no improvement from DBS. Speech will not get better, balance will not get better, memory will not get better, and drops in blood pressure will not get better. But the list of things that do get better is much longer. So And then what are the complications? You're going to say, what are the side effects? So there's a 2% risk of bleeding in the brain after the procedure. 2%. Doesn't mean it's a 2% risk of death. No, but certainly after the procedure, they do MRI and they see in 2% of cases, they see a little bit of blood and it goes away. Nothing to worry about. Infection, any surgery can have risk of infection. It's usually very minimal. I haven't seen it ever. The device can go bad. You can have, let's say, if you're in whatever, you can break that wire and it has to be replaced if you break it. So these are potential side effects. Now let's switch gears and talk about MRI guided ultrasound. That's important because it's a newest edition, was developed in Israel and then was moved to University of Virginia. We've been doing it for probably 4 years or so at Cornell. Initially, it wasn't covered by insurance, but now it's covered by insurance, which is great because both the hospital fees and the surgeon fees are covered by insurance, so you can get it. Now, what are the cons and pros of that? As MRI suggested, this is a focused ultrasound therapy. So no scars on the skin, your skin is not cut, your head is shaving. They have to shave your head to put a special helmet, and then they shoot the laser beam through ultrasound in a deep portion of the brain. The same portion we stimulate, but they zap it with the ultrasound. So essentially they ruin, they burn that area of the brain, they destroy that area of the brain, but that fixes the tremor, stiffness, and slowness for a few years only, because it doesn't cure the disease. So disease continues to progress. So in DBS, I just adjust the stimulation as disease progresses. I increase the stimulation. In ultrasound, there's nothing to adjust. So if you're 90, 85, you don't know if you're going to be around in 5 years, whatever, and you don't want to go have a surgery, this would be a good choice. But if you're young and you're definitely going to be around in 5 years, then I wouldn't recommend that because there's nothing we can do in 5 years about that. Once it's done, it's done. So if the effect is short-lived because disease continues to progress, then there's nothing to do after 5-7 years. And even though it's not a surgery per se, the risk of bleeding in the brain is identical to DBS, believe it or not, 2%. Why? Because they shoot that beam of ultrasound through the brain, and on the way to the spot, they can burn the blood vessels and they're going to bleed, same way as with the wire. So the bleeding in the brain, the incidents are identical. And another thing, you can only do it on one side. You are not allowed to have it on both sides. Whereas DBS, you can have it on both sides. So there are cons and pros for this procedure. This is the promising clinical trial. So we finished the newly approved medications, and now we're going to switching gears to talk about promising clinical trials for Parkinson's disease. So let's start with symptomatic therapy. So this is a most important thing that I want to bring to your attention, the pump. The pump is scheduled for review on March 18 of this year. FDA will render their recommendations. They will tell us whether it's approved or not approved. March 18. So, and this pump is, the name suggests, like insulin pump. Instead of insulin, it's pumping levodopa under the skin. Not you put this little sticker which has little needles. You put it on in your stomach, the abdomen rather, anywhere around your abdomen, and it continuously releases levodopa under the skin, and 24 hours a day. And then I can program that pump to kind of figure out the best amount of levodopa. And the purpose of that is to minimize wearing offs, to get rid of this roller coaster seesaw appearance of your symptoms, dyskinesias exchanging for off periods. So essentially it's a alternative to DBS or MRI guided ultrasound in the sense that it's continuous stimulation. However, the tremor, it will not help for tremor. Only DBS cures the tremor completely. But this will take care of the motor fluctuations. So the idea is that you get rid of all medications. You don't take any medications by mouth. You only slap the thing on your stomach, the abdomen, and it secretes that levodopa continuously, and you don't need any medications, essentially. So that's what the idea is. And we'll know for sure whether it's approved March 18. I spoke with the company. They said that if it is approved, it will be available by the summertime, and so I can prescribe it. So that's the pump. Then the other new things, the Rytary, you've heard of, the long-acting one. The new one will be coming out in the summer. In August, FDA will review the application and they will say yes or no. The new Rytary is only twice a day. Now, the existing one, you can take it up to 5 times a day, which is inconvenient. This one, you take it just twice a day. It covers the entire 24 hours. It's a pill. So it's a carbidopa, levodopa, just like Cinnamid, but formulated that it lasts much, much, much longer, and you only take it twice a day. In August, we'll have the answer whether it's approved or not. Other gene therapy. I'm just mentioning it because it's available. It's not a cure for the disease. The idea here is also, it's a symptomatic. I put it on the category of symptomatic therapy. What basically delivers the gene that makes more levodopa. And so it's supposed to have smooth, formation of dopamine in the brain, but it's not a cure of the disease because Parkinson is mostly just dopamine. Other parts of the brain, is affected. Here is this gene therapy company called Voyager. They're doing phase 2 trial right now. So essentially, I don't remember how they're delivering that thing intracecal. They do like a lumbar spinal tap and they're injecting that. And instead of the brain, and then it gets to the brain, and essentially it makes your levodopa, the dopamine, more dopamine in the brain. So it helps for motor symptoms, but it's not a cure for the disease. And you do it just once apparently. I don't have any patients who participate in that, by the way, but that trial does exist. We don't have any therapies approved to slow down disease progression. Alzheimer's disease recently approved something that slows down. ALS recently approved something that slows down. Nothing for Parkinson. But there are a lot of things in development. Let's talk about it. Biogen, Roche, and UCB. They essentially developing medication that is able to remove alpha-synuclein. Remember, I mentioned that Lewy body, these are particles that deposited in the brain. They're full of alpha-synuclein, which we believe devastating and detrimental to dopamine cells. So the Biogen and Roche developed intravenous formulation when you essentially deliver it through the vein, and it failed. It failed. Now, UCB, and I'm actually running the trial for them at the Hospital for Special Surgery. I'm also on faculty at Weill Cornell, by the way. But I see patients out of hospital special surgery where I developed a movement disorder program. And so I'm running the trial. It's only for very early onset Parkinson, patients who don't take any medications because they don't need any. And so that's the purpose of the trial is aimed to study oral alpha-synuclein inhibitor. It's a pill you take twice a day. It's supposed to sequester, remove alpha-synuclein from the brain. It's a phase 2 clinical trial. It's placebo-controlled, and we just started. So we finished the recruitment already. It will be 350 patients in 50 centers around the world, and it's going to take 18 months to find out whether it helped or not. So that's the thing I wanted to mention too. But it's the recruitment is finished now for phase 2. Now, in 18 months, if it's promising, they're going to do phase 3 trial. So you will be able to enroll if it's available in 18 months. LRRK2 inhibitors. That's another gene that's implicated in Parkinson's disease, especially in Ashkenazi Jewish population. It's called LRRK2, LRRK2 gene, and it's responsible for neuroinflammation in the brain. And Biogen and Denali, the two companies, they are developing medication to reduce that action of that gene. It's in phase 2, very early stage. I wouldn't recommend that because not only you have to travel to California for Denali or Boston for Biogen, it's phase 2. We don't know how safe it is. Phase 1, sorry, phase 1. So wait until phase 2 or phase 3 to really enroll in the trial. But that might reduce the amount of LRRK2 gene. And again, we don't know, but that's the idea. Now, this interesting study that came out using exenatide. That's a glucagon-like peptide, GLP-1 agonist. The drug is used for diabetes, believe it or not, but it's supposed to help for neuroinflammation and mitochondrial function. So it was a phase 3 trial, by the way, phase 2 and phase 3, published in Lancet 6 years ago. And it showed that on the right side of the slide, there was a change in the UPDRS, that's United Parkinson Disease Rating Scale, that doctors like me use to evaluate the changes, the motor changes, such as stiffness, slowness, tremor, how we grade these changes. And then so the study took, lasted 60 weeks, so a little over a year. And they noticed that folks who were taking exenatide, which is this anti-diabetic drug, did better than those who didn't. So it's not approved for Parkinson, but they found a motor improvement, at least in motor perspective. And there are other trials being conducted now on that class of medication. So if you have, right now it's not approved for Parkinson, but if you have diabetes, and it is approved for diabetes, you might want to talk to your diabetes doctor about taking it for diabetes, because it is approved for diabetes, and it might help your Parkinson as well. I cannot and will not advocate to take it if you don't have diabetes, because we don't know how safe it is. Well, we do in a sense that it was relatively safe based on that study, but it's not approved for Parkinson's disease. It's only approved for diabetes. So I will be violating, many laws if I were to advise you to take the medication off label. So it's not approved for Parkinson. But if you have diabetes, then it makes sense to try it, because you can take it for diabetes anyways, and it might take help for your Parkinson anyways. Now, stem cells. So we have a study at Cornell, stem cells, and they're made out of your skin. So take a piece of skin, make stem cells out of them, make it dopamine cells, and they put it in the brain. And they drill a hole in the brain, inject it through the syringe, and it's a one-time deal, and it's supposed to become dopamine cells and slow down disease progression. Now, from the previous experience, we know that these cells live for 5 years, and then they get Parkinson from neighboring cells in the brain. But at least you put a stop on your disease progression for 5 years or so. This study is still ongoing. If you're interested, you can I can get you that information and call Cornell and enroll. They want mostly they actually want advanced patients, not just the early onset, any stage they would take. There's no placebo, meaning if you sign up for it, you're guaranteed to get these stem cells. But the lack of placebo is a negative thing in the sense that we don't have anything to compare it with. So whatever improvement you might say, it might be just pure placebo effect, 2 of my patients had it done, and they're doing okay, but we don't know how, they just had it done in the last 6 months. So time would show whether the deterioration would be any different than people who don't do it, but that's the available thing. So I talked about any different mechanism of action. And then, so last thing I want to end this talk about what I'm doing on sort of my own spare time is that you see, this is the diagram showing different processes that take place in Parkinson's disease. We're talking about misfolded alpha-synuclein, neuroinflammation, mitochondrial dysfunction, and all the companies, what the companies are doing, they just pick a process, they develop a drug for alpha-synuclein, and they think that it's going to cure the whole thing. And I reckon not. I mean, I'm not from Texas, but nonetheless. So how is it possible that the drug just aiming to improve, get rid of alpha-synuclein is going to help mitochondrial dysfunction or iron accumulation or in neuroinflammation? You're really naive to think that one drug can address all of that. So what are the options? You can do sort of a personalized medicine to see what patient has mostly abnormal. Is it mostly on neuroinflammation, on alpha-synuclein, or you could give a combination therapy. That's what I'm advocating for. Give drugs such as exenatide, that I showed you the data, and it addresses neuroinflammation and mitochondrial dysfunction in conjunction with something that addresses alpha-synuclein and, let's say, iron. So give the combination of 2 to 3 drugs, and I think that way we can reach the clinically meaningful improvement. So that's was my idea, to choose 2 to 3 drugs that are able to simultaneously affect different processes in the brain. And this is the diagram, the same diagram, but I put in parentheses different classes of medications that affect each individual portion of it. And so, I wanted to see what if we combine some of these drugs and see where we get. And this is what I got. So I paid my own money to the private research company, and they ran some experiments for me. And this is what I found. So basically, the red cells are cells with Parkinson, the blue cells and white cells, healthy cells. And then I tried to give the drugs to see if I can increase that bar up to kind of cure the Parkinson. So let's say drug number 1 showed this improvement. Drug number 2 is this. When I combine drug number 1 and 2, I got this. It's a combination number 8. And it showed additive effect, maybe even a synergistic effect, which was much increased when I combined these two drugs. Now, you don't blindly combine drugs. I mean, this is all based on these diagrams. So I picked the drugs that strategically that influence different pathways, and they're all sort of available, existing drugs. These are not new drugs like GLP-1 agonist that exenatide, and another one is the chemical chaperone, sodium phenylbutyrate. It's already on the market. So just an example. And that was the length of the neurons. And this is the branch points of how they grow these neuron cells. Same thing. The combination of these two drugs gave me additive effect. This is just one combination that I found to be effective. So that's just a 1 cent on, meaning I am continuing the research. I need help, financial help to kind of get it going. So I'm applying for grants to get this going because so far I had to use just my own funds to pursue this research. Now, how do you find clinical trials? So what are the credible sources for clinical trials? These are the websites that you can use to find clinical trial. I might not know every single one because they're popping up like mushrooms, and I welcome your suggestions. I always say, if you find something I didn't tell you about, send me the information. I'll review it and let you know. Clinicaltrials.gov is a good source. Fox Trial Finder is another website search engine that exists. Center Watch is good, and Parkinson's Study Group. So you can in clinicaltrials.gov you enter Parkinson's disease, enter your zip code, and they'll give you in proximity. You can choose 10 miles, 5 miles, 20 miles near you for Parkinson's disease, what clinical trials exist in case you're interested. And you should ask your doctor to clarify if this clinical trial is right for you or not. And so word about naturals. Obviously, you're going to ask, what about natural? What about vitamins and so forth? So we know that diets rich in antioxidants associated with low risk of Parkinson's disease. Mediterranean style diet showed low risk of Parkinson's disease and Alzheimer's disease. But what does it mean? It means for people who are adhering to this diet from birth, essentially, they have less incidence of Parkinson. If you develop Parkinson and you start, using that diet, it's too late already. So we have not found any vitamins that can reverse or slow down disease progression. There was a long, very extensive study of vitamin E, coenzyme Q10. They all failed, unfortunately. And so the question is, what if you were using it from when you were 12? Would that have prevented or delayed the onset of Parkinson? We don't know that. The jury's still out. So it's naturally good to have omega, foods such as salmon, nuts, and all this Mediterranean stuff. And you're not going to kill yourself by taking coenzyme Q10. The study did show that it did not slow down disease progression. Very large study was published in 2012, if I'm not mistaken. So, but what is proven to slow down disease progression, the exercises. Exercises make your brain produce more dopamine and endorphins, and it's proven to slow down disease progression. So if you have diagnosis of Parkinson, you should engage in as much exercise as possible. You're going to ask me, what kind of exercises? How much exercise is enough? You should exercise every single day. The exercises should consist of stretching, balance, and weight-bearing exercises. So some weights useful, stretching very useful, and the balance exercises are useful. Walking, I walk 2 miles a day every day, not enough. Good, but not good enough. You have to do also straightening exercises, lift weight, and balance exercises, and do stretching far beyond walking. So range of motion exercises for the shoulders, for your legs, and so forth. So that does it for us. I mean, I definitely wanted to leave time for questions, and I'm sorry I went over 40 minutes, but I did want to present that scope of information. And now let's talk about your questions pertaining to what I said or completely unrelated. So I'm all yours.